Backup over here. Yeah, started. Yes. Yes.
Okay, are you
Yes.
ready? Make the screen big.
1 second. 1 second. Okay. Yeah, started.
So, good evening, friends. It's a pleasure actually to meet you again with Meet the Legends program. So, as you know, we have done a lot of programs like this. With Dr. Jayakumar Menon, Dr. GVS Rao, and Dr. Monish Grover, and so many people out there. And actually, we actually want to propagate knowledge throughout the world because this is a web-based platform. And I really thank Professor John Bennett from Miami Beach. He is a professor and he helps us to televise this throughout the world, also on Neurosurgical TV. And there is a TV called Indian Medical TV, so you can see that live. And I'm sure the whole world will be watching this at different parts of the time. So good evening or good morning to all of you. So first of all, I want to thank all the viewers, first of all, because we get a huge viewership, maybe around 10,000, 15,000 people are going to watch this program. So I really thank all of you for sparing your time and making our program more, interactive. So I'm going to brief you about this particular program. This is all about Stapes surgery. And we are going to discuss A to Z about that. And please make it very interactive by asking questions and make it lively, so that I will be putting forward the questions to the speaker. Now, to introduce the speaker, today's speaker is one of the doyens of otology in India. His name is Professor Dr. Manoj Manikoth. So I'm going to introduce I'm going to read his biodata. He was actually a student of Chengalpet Medical College, and he did his DLO from Madras Medical College and MSENT from Calicut Medical College. Dr. Manoj Manikoth is actually an otologist, and he is from Kerala. So those of you who have tuned in from other parts, other countries, Kerala is the southernmost tip of India, and he is actually from that place. So then what happens is that he got trained at Bionic Ear Research Institute, Melbourne, Australia, Cos Clinic, and Béziers, France, Wurzburg University ENT Hospital in Germany, and Kidwai Memorial Cancer Hospital, Bangalore. So he's also a head and neck surgeon, trained in silentoscopy as well, and he also does microvascular surgery. So now, to tell the highlights about us, he's got a long CV. So I'm going to tell the highlights about what he's done. So he has started the neonatal hearing screening program in Calicut, which received the Governor's Award. So Dr. Manoj is a Paul Harris Fellow, started his own center called MESIARC, ENT Institute in 2006, and is at present one of the best equipped ENT hospitals. On a personal note, I would like to say that I have visited his hospital, and it is one of the best hospitals in India. And his operation theater is simply, you have to visit to realize what I'm talking about, because it's one of the best operation theaters I've seen in this country. And he performs a large number of pediatric cochlear implants. He's actually basically an otologist. He performs a lot of cochlear implants, and he's performed over 1,000 now, with a very high proportion of children less than 2 years old, including India's largest bilateral cochlear implant program. And he's performed India's first bone bridge surgery, and he's got special interest in lateral skull-based surgery as well, including acoustic neuromas, globus tumors, Peter's apex lesions, middle ear surgery. But his main interest is on Stapes surgery, and that's what he's going to talk about today. Dr. Manoj's hospital is accredited for many firsts. He's done the first laryngectomy in Kerala, the first neonatal hearing screening in Kerala, the first cochlear implant in Kerala, the first center to do microvascular surgery in Kerala. So India's high proportion of very young children implanted is also from his center. The first voice lab in Malabar, the first salivary endoscopy center in Kerala, the first bone bridge in India. So he's got a very long biodata. So I'm going to cut it short because basically Dr. Manoj, I know him as a person. He wants to his work to talk rather than we talking about him. He wants his work to talk, and you will see why we chose him as a legend. You will see during the lecture how he does it. To me, on a personal note, he's one of the best Stapes surgeons I've ever come across in the world. I've been traveling around the world, but he's one of the best. So we are going to know all about Stapes surgery today. And ladies and gentlemen, you can ask your questions through Facebook Live, or we have given the website on which you can actually see us, and you can ask your questions. And we will sometimes stop Dr. Manoj to ask these questions, and he is very happy to answer the questions. Before we start the program, I also want to announce a few more programs which we have already fixed with Alembic. You know, Alembic is always meant for academics. There is nothing more than academics with Alembic and Royal Pearl. So we're going to do a program on 5th of January, that is 2019, the first program. And we dedicate this program to Professor Heinz Stamberger. So I just want to convey my deep, sorrow from my heart, bottom of my heart, because we heard that Professor Stamberger is no more with us. And actually, this program also is dedicated to that great gentleman, even though he's a rhinologist and this is an oncology topic. But whatever we do today will be actually dedicated to Professor Stamberger. Actually, and we are doing a program on 5th just on Professor Stamberger. And we'll do one program on 19th January, mark your date, with Professor Mohan Kameshwaran, who is another leading otologist in the world, and he's going to talk on implantable hearing devices. This is on January 19th, Saturday night, live for you. Now, we will straight away go on to the topic, Stapes surgery by Dr. Manoj Manikoth. Over to you, Dr. Manoj. The stage is all yours.
Hello, can you hear me?
Yes, we can hear you loud and clear.
Okay, now, good evening, everyone. It's pretty late for many people, but for Janaki, I think the day just begins. For people like us, we all work late nights. So it's glad to be meeting.
I just want to tell you that this is being viewed by various parts of the world. Sometimes in America, it can be even morning. And there are people now from Mexico who have joined. And so we have Indonesians who are actually sitting through 1 o'clock and things like that.
Wow,
so
wow.
there is no time frame here. So it's the world here watching you.
It's like Freemasonry, as the sun never sets. Okay. Now, I'm glad to be joining here. And when Janaki told me this, I was a bit anxious because I've not spoken to audience who was not exactly fun. But it's a very new experience. So let's start off with this now. And like my dear friend Janaki said, I bow before Professor Stamberger, because he, I think, is a man who changed a lot of things in the end. I think he brought about a sea change in the way things did. And to imagine that at 74 is no longer with us, it made me sad the whole of yesterday. Anyway, so let's straight away go on to the screen share, shall we?
Yeah, please.
So I will be now sharing my screen with you, and I'll be running my presentation. So can you see the screen now?
Yes, please. Yes.
Okay. Now, we call this topic Stapes surgery from A to Z because we would like to cover everything that is to be talked about in Stapes surgery. Now, we all know that Stapes surgery, autosclerosis is a metabolic disease that involves the aortic capsule and the ossicles. There is abnormal resorption or deposition of bone, and there is fixation of Stapes, which we would see. The fact that there could be this metabolic disease and resorption or deposition of bone without actual clinical hearing loss is something that we should never forget. But for many of us, patients present to us with conductive hearing loss here, and some of them even have sensorineural hearing loss. along with conductive hearing loss, what we call mixed hearing loss. And there are some people who present purely with sensorineural hearing loss. We must never forget, however, that otosclerosis is a progressive disease. What could be a purely sensorineural hearing loss tomorrow could be a mixed, and tomorrow could be a complete sensorineural hearing loss, irrespective of what you might be doing to the patient today. Now, why do people get otosclerosis? This is something that we always wondered. When we were very young, I remember that when I passed my postgrads 30 years back, we all thought that otosclerosis is purely a genetic thing. We thought that if your mother or father gets it, you will get it. And people always thought that pregnancy would make it worse and so on. But the exact cause is still unknown. Two-thirds of all patient otosclerosis have family history of hearing loss. It is supposed to be autosomal dominant condition with incomplete penetrance. Infections, we have our dear friend, Professor Arun Gadre, Janaki also knows him well. He had actually brought out this paper about measles being a causative factor in otosclerosis. They have found that there was a virus RNA sequence found in active otosclerotic lesions. Because this explains something very different, because people at that time did not understand why over a period of time otosclerosis cases got lesser and lesser. When we were young, there were surgeons, brilliant surgeons, who were doing hundreds of otosclerosis a month. There was, in particular, there was a Lempert Hospital in Chennai, where the Professor Subramaniam used to do minimum 3 otosclerosis cases a day. And suddenly, over a period of time, this disappeared. People stopped having otosclerosis. I mean, you all wondered why. This probably explains it, because when you have something called a viral thing causing otosclerosis with vaccination going around all over the world, it is quite feasible that otosclerotic cases come down. There is also something called autoimmune, type 2 collagen, metabolic, and other endocrine disorders like Pages, which can cause stapes fixation. But I think for now, we will look at 2 major causes. One could be a genetic, a second could be the viral RNA thing. As for any disease, there are multiple treatment options. And whenever you have multiple treatment options, we know that nothing is actually the best. So there is medical treatment. We have many years have used sodium fluoride, but of course, over the past many years, we have never used it, at least me, not for the last 15 years, because we know that one, it probably doesn't change anything. Second, there are some undesirable side effects, so we don't use them. Biphosphonate of late has been touted as one of the methods in which we can stop the progression of otosclerosis. This is still something that has been explored. Personally, I've not used it, but there are people who have used it. We all know that for anybody with a hearing loss, hearing amplification is a good thing. So you can use hearing aids for otosclerosis. In fact, whenever a patient comes to you with otosclerotic hearing loss, one of the first things that you can tell him is that if you have a hearing loss, a hearing aid is probably the easiest thing for him to do. That is something that should never be forgotten. And of course, there is also surgery. Surgery, you can put them under 4 main headings. One of them was the old stapedectomy, which is a second in my list there, where you completely remove the stapes and you put in a process after putting in a fat or a vein plug. Now, the issue with stapedectomy, even though it worked brilliantly in many people.
Now, Dr. Manoj, can I stop you for a question, please?
Oh, please.
So, one of the participants wants to know, do you give sodium fluoride at all for otosclerosis?
No, I did mention that I never give sodium fluoride. I've never given sodium fluoride for the last 15, 20 years. And I have not started giving biphosphonates, even though I'm still waiting for that particular thing. I am asking a few people how it is being done. There are some results, but one of the things that we don't get is this active autosclerotic foci. So I would still keep my my reservations on that. I don't use them, frankly.
Okay, thank you. Please.
Now, stapedectomy was something where I mentioned you to remove the whole stapes. Now, what happened to people with stapedectomy was that they tended to have good hearing over a period of time. There was, of course, considerable dizziness. We had people who had surgery. I've seen personally some of the old starvers operating. Patient had severe dizziness after surgery. A lot of them tend to have good hearing, but there were a significant amount of people who tended to lose hearing over time, which is why John Shear actually started off stepedotomy, where he actually said that you can make a small fenestra put in a piston to the size of the fenestra, and you can close off that fenestra opening with a vein or fat or whatever. And by retaining most of the Stapes footplate and removing the superstructure, you would actually give far better results. And I think that was the single most important advancement in orthopedic surgery. People started doing surgery, we started having long-term good results, but they were still failures. We shall come to that later. There is, of course, bone conduction implants. For somebody who's got severe hearing loss and who's not willing for orthosclerotic surgery, or somebody who's too old, probably is unfit for surgery, you still have a bone conduction hearing aid. Like the bone bridge or the Baha, or even a vibrant sound bridge put on the round window, could still give you conductive hearing part, amplify the conductive part of the ear, and give serviceable hearing to the patient. Cochlear hair implants have also been useful. Personally, I am operated on 7 patients with autosclerotic hearing loss, profound listening HL, and cochlear implants are a miracle. For somebody who has had failed surgery, who has got profound hearing loss in both ears, who thinks that the world is at its end and cannot do anything more, cochlear implants give phenomenally good hearing to people. I have patients who talk to me over the phone to me. Now, these are the treatment options. Now, what has changed in surgery? In the 80s, it was very fashionable to do Stapes surgery. Stapes surgery was the, what do you call that, the Kohinoor, like my friend Suri says. It was given to have vertigo. When, suppose they said that if you do a Stapes surgery properly, patient must be dizzy. And taste alteration was something that was a given, because you always cut the cord out. Stapedectomy was the rule. Vein interposition was used. Processes were pretty crude. They were made of wire, they were made of fat. Imaging was never used. We never thought about imaging because those days, one, CT scanning was not there. CT scans, even though they were of very poor resolution, there was a strict no to surgery in only hearing ear. People said that if you have one ear that is gone deaf, no one should touch the other ear. People also did not operate in severe mixed hearing loss. Lasers were uncommon, even though Perkins did develop it. Microdrill was unheard of. In fact, microdrill came after the laser. And processes were very crude. And hearing loss is something that was noted very often. People said that there was a very famous surgeon who used to tell people that you will hear for 30 years and then you will go deaf. And a lot of people did turn out that way. We do not know how. But now what changed now? It is still fashionable to do Stapes surgery. People who do Stapes surgery stutter out as if they do something seriously big. Vertigo and alteration is considered an error. If somebody comes to you for Stapes surgery and you do surgery and the patient is dizzy, you would say that something has gone wrong in the way in which you did surgery. That's what it is. And technically, you should have no alteration in taste. People should go back with a normal taste. Stepidotomy is the rule. I don't think, unless it is a very exceptional circumstance, which I will actually tell you later, stepidotomy is the rule. We don't do stapedectomy. People use seal, people don't use seal, which is not very, still don't approve. Jan Bernard Cosse in the Bezier, in Cos Clinic, actually had propagated this whole technique of using the vein graft, which he said was mimicking the annular ligament of the stapes. But over a period of time, multiple studies have not proven that a vein graft is actually superior. Processes have become very sophisticated.
Can I interrupt you for a few questions from our audience? Okay, Dr. Shah Wali is asking you, sir, what's the role of CT scan in diagnosing autosclerosis?
Can I come to that later? I am going to go do that. Okay. I'll be handling that in great detail when I'm dealing this.
Okay, so the next is from Somasundaram Chakkingal. What is the lowest stage of the patient diagnosed with autosclerosis?
Autosclerosis in children have been reported. In fact, the youngest child that I operated was 7 years old.
Okay.
Yes, and this was his sister, who was 11, was operated by me when she was 11. And when they bought the younger boy, I thought of something else. It was also autosclerosis, and I operated him too, and both of them in both ears. And the first surgery was done, I think, 11 years back. They are big children now. Still, the hearing is good. I have operated on many children in the age group between 10 and 12, but 6 was probably the lowest I operated. And I looked at literature. I think there have been reports of children between 5 and 6 who have been operated. So it's not unusual to have hearing loss. autosclerosis. You can also argue that it's probably not autosclerosis, probably congenital stapes fixation, but in effect, it's all the same.
Yeah, please carry on.
Okay. Now, I shall now first demonstrate what is an optimal technique to do stapes surgery. Okay, because when whatever we talk later is going to be related to what we are doing in stapes surgery. So this is my video on the optimal technique. It's a short video. It just shows you what should be done. I'll be talking along with it. If you want, I can run it through again. Now, the critical steps in stapes surgery are: one is to make the proper incision. The incision, the anterior incision, should start in front of the handle malleus, because there might be some case with stapedial fixation. You raise the tympanomeatal flap, and then you have to see the round window. Why do you have to see? I'll pause it a minute here. Now, why do you have to see the round window is that, see, one of the important things in orthosclerotic surgery is that there are two cases where you don't operate. In fact, you don't operate at all. One is where you have a pulsatile round window. A pulsatile round window is a sure sign there's going to be a gusher. This is actually an X-linked condition, X-linked recessive condition, which can happen with a wide cochlear aqueduct. Happens in young males. Many members in the family have deafness, and if you just about touch the stapes, gone, you're going to have a profound hearing loss. The second condition where you don't operate is where you have a orthosclerotic focus on the round window. You don't want to mess with that. So your first incision should be able to show you the round window. You can see the round window here. Now, if you look at the round window closely and if it's not pulsating, then you can actually pretty much eliminate the possibility of a gusher. There's one thing that you need to do. So I shall go back on that thing a little bit more. So when you open up here, you see the round window, which is what you want to see. You may or may not see the ossicular chain at that point of time, because generally when you look into the middle ear, when you open the tympanomeatal flap, you will see the incudostapital joint and probably part of the stapes crura. I shall go through the video once again. So now what you do is then you have to curate. The curating has always got to be done away from the ossicular chain, because there you will prevent an inadvertent injury to the ossicular chain. Now I will actually freeze it here now. What have I done? I have actually dislocated the incudostapital joint. This has actually been described many times by Peter Wanson, who is from the Cos Clinic, who said that the only way to actually eliminate the possibility of a malleoinguinal fixation is by dislocating the incudostapital joint and moving the malleus, so that you know that that is moving freely. And then you touch the stapes, because we always used to originally touch the stapes. The stapes will still not move if there is malleoinguinal fixation. So this is what we have done. You can see it again. So I shall rewind a little bit more. So you take a small knife, cut the incudostapital joint, and then move the malleus. Can you see that? When you move the malleus, you will have the movement. And here, what you do is that you can actually reduce the posterior crura of the stapes. Now, the crura of the stapes limits your view of the round window. I'm sorry, the oval window. Now, you can remove the crura with a fine instrument. You can remove it with a lathe, or you can remove it with a micro drill. The advantages of removing are twofold. One is that you actually see the footplate very clearly. Second, you're weakening the crura. Here again, we are talking about a complication. So I'll be talking about complication in this very slide. Now, if you do not weaken the crura, at the end of the procedure, when you take out the stapes, what can happen is that the force that you apply onto the stapes, depending upon whether the focus is thick or thin, can actually dislocate the stapedial footplate and cause vertigo and hearing loss. You don't want that to happen. So you have to weaken the crura. This technique was actually taught to me by Dr. Ashish Bumkar, who many of us in India knows, one of the most well-known otologists and well-known pinna plastic surgeons in this part of the world. So he...
Manoj, just want to interrupt you here. Again, Dr. Ashish Bumkar, he does what is called the amputation of the head. What is your comment?
I will come to that thing. He has, I've done it a few times. It is nice. Because there you don't do anything. But I will come to that later thing. Now here, when I make the crura thin, I can see the whole foot plate. I can also decide what length of the piston that you need to keep, which is what I'm doing here. So the ideal length of the piston that you keep should actually go into the vestibule no more than half of the thickness of the incus long process. Now, how do you do that? Because when you keep the piston here, that's a stem of the piston, that's a ring. And if you keep the piston on the foot plate and the stem touches the incus, if you put the fenestra, if you put the piston into the fenestra, it will only go in that much depth into the vestibule. Because see, you are talking about the saccule that is far away from the foot plate. Distance between average distance between the foot plate and the saccule is about 2 millimeter. Now, if you put in about zero point 0.4 or 0.6 millimeter inside, you are not stimulating the vestibule, thereby there will be no vertigo. So here is what I'm doing. I'm actually measuring the distance. See, can you see that? I'm actually kept it there.
Yeah.
Yes. Did you say something, Janaki? No.
No. I just said yes, we could see.
Okay. Now here, what I'm doing is I'm drilling away the anterior crust. Now this is not very easy to do. You have to take the micro drill and drill away the anterior crust, because here we are weakening not only the posterior crust but also the anterior crust. But sometimes this is not feasible. You can elevate the mucosa over the foot plate. This can be done, because when you elevate the mucosa over the foot plate, you are having a foot plate that is nice and clean, into which you can actually make a drill hole and not allow blood to get inside. There are two major enemies of the vestibule. One is bone dust, second is blood. So if we don't allow bone dust and blood to get into the vestibule, or even in a cochlear implant, you actually preserve hearing. We all heard about that. So here what I'm doing is we are actually going to drill the foot plate now. And before that, you can take out a vein graft. So this is a technique of taking out the vein graft. You take it, you remove the adventitia, and you can spread it and take a nice 2-3 little pieces. So here what we are doing is that I will freeze it now. You are drilling the foot plate. Now the foot plate drilling should be done in an extremely slow manner. It should be micromillimeter by micromillimeter, which means that you actually make it thin, and then hold. Now, one of the things that you do when you drill is that bone dust collects there. So what do people do? They take a little sucker, a 26 sucker, and suck it out. This is bad, because you might have a little hole which you'll be sucking out, and then that will cause vertigo. So one of the important methods of doing this is by using a small piece of gel foam. You see that there, putting it on the foot plate, and that will suck out all the water or the fluid or the blood or whatever, bone dust. So thereby you can have an atraumatic suctioning on the foot plate without actually causing any movement. So you can, I shall run this once again. So here it is.
Can I stop for a few questions, please?
Yeah, please.
There is a doctor called Farooq A. Khan from Saudi Arabia who wants to ask a question to you. He says, Professor Manoj, we know stretching of cardia tympani nerve is more harmful than cutting it.
Yes.
What do you believe about it when it comes in your way?
Yeah, it is absolutely important. See, the whole technique of chorda removal, which I shall, if you are time permits, I can show you later, is that when we actually are curating the bone, you actually curate the chorda canal. Now, what you see, the chorda that is seen here is not stretched. It is actually separated from its canal. So you should never ever stretch it, because I should show it to you at the end of this presentation. When you put the chorda back, it should never look stretched. If it is stretched, it is gone. So if at all you have, think that when the views, like for example, today's stapedectomy was a very difficult one, very narrow canal, a very short incus. So I had to actually cut the chorda. So you can either cut the chorda or separate it, but never stretch it. I'm glad you brought that out, but we shall be talking about that later.
So one more question from Dr. You don't mind taking questions, right?
I'm fine.
Okay, Dr. Minish Juvekar from Bombay.
Oh.
Hello, Dr. Manoj. Have you, in your experience, seen a vein graft helps in reduction of postoperative giddiness?
It's a great question. Okay, now let me tell you what I did. When in my first many years of doing surgery, I used a micro pick and fat and no vein graft. Now this was the time when there was a lot of giddiness happening. There were people with giddiness. There were people who had unsteadiness. This all happened. Then I switched over to the skeeter and the vein graft together. Now, when I started using the vein graft and the skeeter, patients stopped having these giddiness. Now, I did not know at that time which was a skeeter where I was weakening the foot plate and they were causing no trauma on the foot plate, or was it the vein graft that was causing less acoustic trauma. And then I met Dr. Anand from Bombay. So he told me that Manoj, in Chutlingen University, they don't use the vein graft. They just put it in. They, in fact, don't even seal it. So for many cases, I stopped using the vein graft. And I followed these patients up for many years. And I found that there was no real difference between these two people when you use the vein graft and don't use the vein graft. So, and when I started using the laser, which we will see later, I stopped the vein graft altogether. So right now, my vein graft use would be limited to situations where I have to remove a large part of the foot plate, or if I, in some cases, revisions when I take out the whole foot plate. So right now, no vein graft. So I don't think it really matters. I think what matters in preventing giddiness and postoperative was, I think, making a proper side fenestra and not causing a rocking movement on the foot plate.
Thank you.
Yeah. Yeah. Now what? See here, I'm making this drill. I am suctioning. I'm making the drill. I'm suctioning, and then you have this nice round hole, and I keep the vein graft over there. This is the whole technique, and then you put the piston into the fenestra, and then hook it onto the incus. Can you see that? This should be one gentle.
Beautiful.
Now, see, the technique should be like this. It should go into the vestibule, onto the incus, not onto the incus, into the vestibule. Okay, now I will rewind it a little bit better. Okay, now see, you have seen this vein, the chorda here. The chorda looks absolutely normal. I shall show this once again. Now the chorda is now being repositioned and looks normal. If it looks stretched, it is gone. The Stapes chorda can be removed or cannot be removed. Now there are some people who just fracture it and now it will lie on the promontory. There are some people who remove it, but removing and not removing, I don't think it really matters a lot. But I have had one case where when I had fractured, this somehow had come back and then fused again. So after that, I always remove it. So, and then we will close the wound and we will see the small vein graft, which doesn't have to be closed. So that's a video on autosclerosis. This is a general base video to tell you how to prevent complications. So once again, chorda injury should not be there. You should not have a tympanic membrane tear. You should prevent a gusher by anticipating it up front. You should not operate on somebody with a fixed round window, autosclerotic focus on round window. We should not cause movement on the foot plate. We should make the fenestra exact middle of the Stapes foot plate, because anything anterior might cause dizziness, anything posterior might have poorer hearing. So the ideal thing should be middle. How do you know it's a middle? Only when you see the whole foot plate. So which means that if you remove the posterior crust, you see the whole foot plate, then you can decide where to make the fenestra. We should not put too long a piston, which will cause dizziness. Too short a piston, that will cause perilymph leak. So that is why you have to measure. And then you can, by putting it first into the chorda, into the vestibule, and then onto the incus, will prevent dislocation of the incus, because that you are doing it under vision. And then by closing the flap and ensuring that there is no tear, because a post-operative chronic otitis media is something that you and I don't want. Now there are many kinds of pistons available. Now you have these fluoroplastic pistons, which I use most of the time. I use these titanium pistons also. Now there was a period of time where I used only titanium pistons. I think it was for about 3 years. I did only titanium pistons. The Curus soft clip that you see here, brilliant pistons. And then I try to compare what I'm seeing with a titanium piston vis-a-vis a fluoroplastic piston. I found out that there was actually no difference, because I stopped that and then started doing the fluoroplastic again, because there was no short-term improvement in the cells in between those two. And then after 3 years, did again audiograms to find out whether there was any change between these two. I agree 3 years is too short, but there's actually no difference. So right now, my protocol is to use a fluoroplastic piston here most of the time. Use a titanium only when I find a very thin incus or a very thick incus, because when you have a very thin incus or very thick incus, you can actually damage it by using a piston which could not sit completely on it, or could actually move and then cause necrosis or incus long process. So if I have somebody with a thinned out incus or somebody with too thick incus, I use the titanium clip. I use nitinol also. So that this is a nitinol processes where you can put it there, and using a shot of laser, you can make it shrink, which means you don't need to crimp it. But due to the extreme cost, I don't use it anymore. Now about diameter. What diameter would you use in Stapes surgery? There have been a lot of studies. You can see that Shabana in 1999, Fish in 1982, Silverstein in 1998. And they all did a lot of these studies and found out that there was significant better closure in the 0.6 millimeter group. A lot of Stapes surgeons use a 0.4 millimeter because easier to manipulate. I use a 0.6 because I also believe that from changing from 0.4 to 0.6, I did find out there was better closure of the airborne gap in the lower frequency. So I think it's important to have a 0.6 millimeter, unless of course you have some condition where you can't put in a 6 millimeter. It's very influential. So you have a lot of studies. You can see all this. So there was without interposition, 0.6 millimeter associate better results than 0.4 millimeter. Now, there have been very good surgeons who still use 0.4 millimeter, but they all say that if you use a 0.4 millimeter, it's better to use a vein interposition. 0.6 millimeter, you don't have to. This is again debatable. Now, one of the reasons why I started using 0.6 was because of this. Now, we get a lot of patients like this. Can you see this? Severe mixed losses. Pardon?
It's clearly seen.
Can you see it?
Yeah, very clearly seen.
Pardon?
It's very clearly seen. It's very clearly seen.
Oh, very clearly seen. So now you can see these people have about 95 dB low frequency and about 70 dB high frequency loss on both sides. When I was using the 0.4 millimeter piston here, I never got these overclosures in this group. So I think that is one of the main reasons why I shifted over from a 0.4 to a 0.6. Now here you can see that this patient has been shifted from 90 dB hearing loss to 50 dB hearing loss, better than the higher frequency, which means that technically this patient is not a hearing aid candidate, becomes a hearing aid candidate. Now this is something that is important when you do Stapes surgery. You can also see that over a period of time, these are patients who have been operated. This is 1 year later, this is 2 years later, and 17 to 18, the hearing improves and improves till it becomes preoperatively, it is 63 and 67, and 2 years after surgery is 23 and 20, which is what we need to see in otosclerosis surgery. See, if you want to have good hearing, what do you need? You need to have 30 dB in at least 1 year, or you should have 40 dB in both years. This is the type of hearing that you need to avoid a hearing aid use. So this is exactly why we do surgery. Now, somebody asked me about CT scan. Now, there is indeed two things about CT scan. One is that you need to know the CT scan to find out if there is cochlear otosclerosis. Second, you need to know to find out how thick the foot plate is. And third, you need to do a CT scan to find out if it is something else other than otosclerosis. Now, we shall be dealing with all of them as time goes by. Now, this is a Simmons and Fanning grading system for otosclerosis. What you see here, 0 is when there is no otosclerotic foci. Grade 1, when there is only this foot plate is actually thickened, and you can see thickening here in the foot plate. And 2A, 2B, and 2C is when the cochlea is involved. 2A is when only the basal turn is involved. You can see the basal turn involved, the middle turn apical turns free. 2B is when the middle turn and apical turn is partly involved, and 2C when there is complete involvement, and grade 3 when there is complete opacification of the whole cochlea, when you get what is called this pericochlear lucency, so the double halo sign, which is a telltale sign of cochlear otosclerosis. Now, when you operate a cochlear implant on these patients, you should use an implant that is not stimulating the facial nerve, which runs like that here. So if you have an implant, a full banded electrode, in this case, this bone is so spongy that every time the patient hears something, the facial nerve will twitch. So this is one reason. Now, how does imaging influence surgery? This is what you do. See, this is what you do. If there is speed discrimination is less than 30, you go directly to cochlear implantation. Don't worry. This is for advanced otosclerosis. So if there is 30 to 50%, you do a CT scan. If it is type, you see if it is type 2C or 3. If it is no, the airborne gap is more than 30, you go for stapedectomy. If the airborne gap is less than 30, you go for cochlear implant. Whereas type 2C or 3, you go directly to cochlear implantation. If the speed discrimination between 50 to 70, you do a CT scan, do a CT scan, and then same thing, there is no types 2C or 3, airborne gap more than 30, you do stapedectomy, and if it is not more than 30, you do a hearing aid. So the arm between whether you do a hearing aid or a cochlear implant or just CA alone depends upon speed discrimination. So this is how imaging would influence your decision making, whether you give a hearing aid, whether you give a stapedectomy or a cochlear implantation in those cases where there is far advanced autosclerosis. I do agree that to do a CT scan just to find out every case of autosclerosis is actually a bit of an overkill. But there are a lot of people who use it. Now, we use a lot of tools for stapedectomy. One is the micro drill. You have two major kinds of micro. There are plenty, but there is one, the most used one. This is the Zomed Skeeter. This is a Bean Air Auto tool. Both of them are brilliant. They are equally good, I would say, except that the Bean Air drill tips are much more expensive, but they say they can use it many times. Skeeter's tips are fantastic, very light, but they are technically only meant for single use. So, but we do use it for 4 times after plasma sterilization. But if you want to be using your drill bits for a longer period of time, you go for them. But if you want a little bit better precision, you go for these. The one advantage of using the Skeeter is that most of you have a debrider at home, the Medtronic, which can be fixed onto the Medtronic debrider. Now, I shall show you a small video how the Skeeter is used. Can you see this is a very thick foot plate, yellow colored foot plate, and the Skeeter can go there again and again and again. This takes many minutes. You can see how long we do, and then keep on drilling and drilling and drilling till it thins out. So this could never have been done without a Skeeter. So you can take a hand pick and make out a drill hole. This will be like making a burr hole in the skull, which will be just there. But whereas a Skeeter, it will thin out the entire foot plate, and then you can make a fenestra exactly where you want. And this thing can never be done with any other instrument, not even a laser. If you want to have a very thick foot plate, if you thin it out completely, and you want to fashion your fenestra exactly where you want, you need a Skeeter. Now, laser can eliminate many dangers. What is the purpose of using a laser? One is that laser can eliminate bleeding during cutting the tendon. It can prevent rocking of the stapes during movement of stapes superstructure. It can prevent fracture of the foot plate, and it will prevent excess mobilization of the incus. Now, there is also a comparison between the slide should have been before that. There is stapedectomy and stapedotomy, and they say that there is no statistical difference between two groups. Now, I shall show you how we do a laser stapedotomy. So this is a patient with the 43 years mixed hearing loss. You do the same steps as the other one. The chorda is not retracted. Can you see that? The chorda is kept there. The laser is to cut away the tendon. Then you look at the fenestra, make that hole. One shot. That's all you need. And put in the piston. Like I mentioned earlier, no vein graft. So the laser, when you use a laser, it makes one, here I'm using a small fat graft, but you don't even have to use it at times. Now the laser, the advantages of laser is that most of the troubles that are coming to you when you're a learner surgeon is eliminated. My friend Erwin Officius was telling me that in their university in Netherlands, when they compared the results of trainee surgeons vis-a-vis the experienced surgeons using laser, there was not so much a difference. Because when you have somebody training, the damages happen when you dislocate the foot plate, when you make too deep a fenestra or too superficial a fenestra. All these things are eliminated by using the laser. But then if you ask me whether it is worthwhile buying an expensive equipment to do a stapes surgery, I mean, it's your takes. It all depends upon what your surgical load is. Now, vertigo and technique. Now, there has been a lot of studies on what kind of, I mentioned that when you do a laser stapedotomy, you're making a small hole, you're not touching the foot plate, thereby you can actually eliminate vertigo. Now, there has been a study which compared the risk of SNHL and tinnitus with microdrill laser and other techniques. So, where all but one study had higher airborne gap closure in the laser group. So if you compare all these studies, Hostler, a very famous man, and Badran, Barbara, so and so, they were all studies, group 1, had higher AB closure in the laser group, probably because you're making a better fenestra. Risk of SNHL was higher in the micro drill group compared to the laser group. Strangely, tinnitus was more in the laser group. I have not actually seen that in my series, but there are some people who complain of tinnitus, not very specific to what technique you use. The most important thing here is that there was no foot plate fracture in the laser group. So if you want to eliminate a foot plate fracture, you should use a laser. Or you should have extremely skilled hands in other people where you can use a drill millimeter by micromillimeter and making a small fenestra. I've seen some brilliant cases.
Can we stop for a question,
Yes,
please?
yes.
So Dr. Uday Muthukumar wants to know, in case you have a dehiscence of the facial nerve, is it still, you can use a laser? Is it a contraindication?
Yeah, that's a good question. Now, Muthukumar, see, when you touch the laser when you touch the facial nerve with the laser, you get a paralysis. There's no doubt about that. And that's very bad. So when you have a foot plate dehiscence, which is laser, the facial nerve is coming onto the foot plate, it would be advisable not to use the laser. You should not. But of course, there are some techniques. What you can do is, see, generally the foot plate fracture, the facial nerve prolapse is not exactly the facial nerve prolapse. Now, the facial nerve is covered by a sheath, and there is fluid between the actual nerve and the sheath. So when you have an area where the bone is not there, what happens is that the fluid collects in the sheath and the sheath prolapses. So it is not the facial nerve that is actually prolapsing. You have an abnormal facial nerve running on the foot plate where you don't want to do a staphyrectomy. But if you have a sheath prolapsing outside, what you can do is you can take a small elevator and push the facial nerve for some time. And if you leave the elevator there for about 1.5 minutes to 2 minutes, when you take out, voila, you don't see the facial nerve. There you can actually use a drill and or a laser again. So if you actually see a facial nerve that is outside, you can actually try compressing it. I've done it, and which actually doesn't seem to do much harm. But if you have a facial nerve that is running across the foot plate, then of course you don't want to be touching that with the laser or a micro drill or with any other instrument. Does it answer your question?
I think that answers that. Do you have any classification of the facial nerve running over the foot plate?
I think there is, but I really don't know, Jangam. I don't know. Do you know that? Do you remember?
No, I don't know.
I don't know. I think I read it somewhere, but I don't. It is not standard, so I don't remember.
So, what is your take on maybe if there is maybe the half of the foot plate, the facial nerve is running over it, you still move that facial nerve and put it, and what happens to the piston? Is it pushed off later at a later date?
Because it is the sheath, the neural enamel sheath with the fluid that is coming out. This coming back onto the facial nerve does not seem to be affecting the piston movement so much.
Okay.
So I've actually followed these patients for many years, and we have not found these patients having further hearing loss or any slippage of piston.
Okay.
Now, there is also one more laser that you can use. There is a KTP laser. But let me warn you, KTP laser is not the ideal laser for Stapes surgery. It does many good things. One, it prevents bleeding. It is fantastic for bleeding, but it is actually causing a lot of heat. So some of my first cases that I did with KTP laser ended up with temporary facial weakness. Terrible. But they all recovered, luckily. So this is what you do with the KTP laser. So the same technique, you are elevating the flap and you're seeing the crura after curating. The collar has been separated. You can use the laser with the touch technique. You can vaporize the posterior crust completely. It's all done with the laser. You can vaporize the foot plate vessels. And over that, you can make a fenestra with the skeeter. So this is done to reduce blood. So if you have somebody with the blood vessel running across the foot plate, a CO2 laser will mess it up, because CO2 laser does not have so much of blood sealing capacity like a KTP laser, unless it is a big.
I have a question, Dr. Manoj.
Yes.
If you find vessels over the foot plate and you don't have a laser, so what do you recommend for these people?
I mentioned in my old, the first video that I showed, you can elevate the mucosa off it.
But it bleeds a lot, right? So for a long time.
You have to elevate the mucosa.
Soaked gel foam, do you recommend?
Adrenaline soaked gel foam should be kept, but you must understand that adrenaline is very autotoxic. So if you are, after you keep adrenaline and you remove it, it's important that you actually put a little bit of saline and try to suck it off to make sure that no adrenaline remains there. Because adrenaline going into the foot plate could be pretty traumatic. So if you're keeping adrenaline over the foot plate to stop the bleeding, which I do sometimes, at the end of the procedure, what I do is I apply a few drops of normal saline and then suck it off to make sure that adrenaline doesn't remove on the foot plate, remain on the foot plate, which is very important.
Okay.
And now, so that's a KTP. Now here, okay, this is a repeat slide. Now there are conditions where you use a micro drill along with the laser. So this is what I said earlier. So here is a patient with a transcanal approach using endolent speculum because a narrow canal. So elevating this thing, the chorda has been separated, and you're seeing a thick vascular foot plate. Can you see that? It is very thick. This is what Janaki mentioned. Can you see that? White and blood vessels running over it. It looks like a sebaceous or something. It is so thick. Now here, what you can do is you are actually using the laser and then actually thinning it out, using the drill again to smoothen it out. Can you see that? So first you have to use a laser to make it avascular. Then you have to blue line it. And once it is blue line, keep the laser again and make a hole. So that's what you do. So that's what it is. So you can actually use this. Here I'm using a Kurz piston because the incus looked, it's a revision case. The drum was sitting on the incus long process. So here the incus was thinned out. So I used a Kurz processes, and I also used a small piece of tracheal perichondrium because I did not want the drum to go sit back on the incus and on the processes, because it is a case which had a timbroplasty operated and where they found out that there was orthostatic focus and did not do anything on the table. So here is this is where you can use a laser, laser again to combine these two techniques to give good results.
So we have a couple of questions, Dr. Manoj. Can we take it?
Oh yes.
Dr. Rajesh Chowdhury wants to know, sir, if the diameter of the vestibular aqueduct is more than 2 millimeters in CT scan,
yes,
should we do staphylectomy or not?
Now, an enlarged vestibular aqueduct is what you're talking about. Now, you must understand that whenever there's an acute enlarged vestibular aqueduct, the airborne gap that you see is not an airborne gap. Sorry, I'll stop this video. The airborne gap that you see is not an actual airborne gap. The airborne gap is actually a third window effect. So if you find an enlarged vestibular aqueduct, never do staphylectomy. Don't do it, because if you do it, what will happen? You will create a leak, a piriform fistula, and profound hearing loss. And you should understand that this airborne gap that you see is actually not going to be. It's not an airborne gap at all. Because day before yesterday, I operated a cochlear implant patient who was actually diagnosed to have a mixed hearing loss. The patient has bone conduction thresholds, bone conduction curve at 50, air conduction at 90, and the speed discrimination in the aided bone conduction mode of 0. How does it happen? It happens because the air conduction that you see in the airborne gap that you see in somebody with a third window, like a Mondini dysplasia, and this particular case was a Mondini, a wide vestibular aqueduct, is not actually an airborne gap at all. So this is again one of the reasons why some people say that you have to image all autosclerosis, but because the proportion of that is so low, and because I do not agree that you should subject somebody to imaging which causes some 600 X-rays worth of radiation just to find out these rare instances, not warranted. But I would definitely do CT scanning when, suppose somebody comes to me with unilateral autosclerosis, unilateral conductive hearing loss. I will always do a CT scan. Somebody comes to me, says that my brother had Stapes surgery and he became profoundly deaf. I will think that there is possibly a third window. I will do it. If my audiometric thresholds are disproportionate to the speech audiogram, if I find that somebody with a 50 dB conductive hearing loss or 50 dB mixed hearing loss has got a speech discrimination of 40%, I would think there's something wrong. So here's where I will do imaging to find out. And like you asked, if at all you have a wide vestibular aqueduct, you will definitely not go and do staphylectomy in this case. Simply not worth it. Is that okay?
Yeah, that's perfect. A few more questions. The people are actually pouring in. There are so many viewers, and really a great lecture you're giving. Lot of appreciation, but a few questions also. Please, sir, this is from Dr. Paromita Saha from Bombay, sir. If incus dislocates, then can you keep a piston between the foot plate and the handle of malleus, or should we abandon the surgery?
Paramita, you're preempting my next slide.
Oh, okay, okay.
That is good. I think she mind reads. Okay, whatever. Now this is I'm going to talk about what is happening. I mean, that's her answer is the next slide.
Okay, please carry on.
If you actually dislocate an incus accidentally during surgery, I mean, I also mentioned during my initial critical steps videos that when you curate away from the ossicular chain, it's highly unlikely that you will dislocate the incus, but dislocation can happen. And one of the main reasons why dislocations happen is because people don't use a good curette. One of the first imported instruments that I ever bought was a curette made by Carl Stoss for stepidotomy. I now have multiple, I have spigelenthize, I have other things, but these instruments are worth their weight in gold. If you have a good curette, you will not damage the incus. But imagine that you have damaged. Now, what would you want to do at that point of time? You can do two things. One, you can leave it there, just leave it there, and go in back again 3 or 4 months later and see if it has refixed back onto the incus, onto the malleus. And if you think it's pretty stable, you can go ahead and do it. But what generally happens is that once you dislocate it, it becomes ankylosed. So it doesn't work very well. So one of the things, if you are familiar with the technique that I'm doing next, if you can do a maliovestibular processes, I think that is the best thing that you can do for this particular patient by taking out the incus and putting in a maliovestibular process, because a loose incus is a danger. You know what can happen? This loose incus, you'll put in a foot plate, piston into the foot plate. Over a period of time, the incus will start sinking. And when it sinks, it will go into the vestibule. And I have seen one particular patient, which is terrible. I saw this patient with his notes that mentioned that incus had dislocated, somebody put in a piston, and then became profoundly deaf 4 years later. And then when I did a scan much later, I found that the whole piston was inside the vestibule, the whole thing. So please don't try to do any tricks here. It's important that you either do a malavestibular processes or try to go in again and see if it is still mobile, where you can do a processes, or you can go to a senior or somebody who is more well versed in this technique. So I shall show this technique where a person actually had a stapedectomy surgery many years back, and over a period of time lost his hearing. So this is a video on the malavestibular process. So here, this is an endoral approach. I just like to have both hands and making the flap. Always use bipolar on the endoral incision, because you need to have a bloodless feed. So you are elevating the canal and inspect the ossicular chain. What is happening here? So this is what I want you to see. So you can see that the ossicular chain, the incus is nearly cut across. Can you see that? Can you see it's nearly cut across?
Yeah, I see.
So here, the middle part, why does it get cut? Now you have to understand. You can see the piston below there. If a piston is loose onto the incus, can you see if it is loose? The piston will move like this on the incus, and that can actually traumatize the incus long process much more than an overly tight piston. People always thought that over tightening was a problem. Over tightening was never the problem. Under tightening was the problem. So if you have it loose, it will move and cause movements on the foot plate, and thereby it will. Because if over tightening was a problem, the titanium process would never last, because they all clip on the incus. So here, I found that this incus was no longer viable. So what I did was I took it out and I bared the malleus handle. Malleus handle must be made bare. It has to be, every bit of epithelium has to come off from the malleus handle. And then we took out the incus, took the old piston out. This was done 20 years back, mind you, 20 years back. And I curated a little bit more. The fenestra was still patent. You can see that. Let me rewind a bit. Can you see that? The fenestra was still patent. And then I removed some of the mucus over it, and so that the piston fenestra became open again. I measured the piston once again, how long it must be. That is a malavestibular processes. And shall go back a minute. Oops. See here, you have a clip and you have a ball and socket joint here. So you can actually put it onto the malleus and adjust the ball and socket joint in such a way that it goes into the vestibule. So here, you are seeing this being adjusted, and that is being clipped onto the malleus, and the ball and socket joint goes into the vestibule. Can you see that? That's how it is. It goes into the fenestra there. So this is a brilliant process, because if you do it properly, you can have really good airborne gap closure with this process. I shall show you some results later on. Let you close. So now there are some studies that suppose nothing works, so that we can do for cochlear implantation, which we will do later. Now, why do Stapes surgeries fail? They fail because of poor visualization, inadequate training, less attention to detail, and rare but unknown factors. Now, what do you do when things don't go so well? You have to prepare yourself for the worst, and I shall show you something. So here was my patient. Okay, this is my own patient, where I shall freeze it now. So I have done this surgery, I think 7 years before this particular video was shot. So she had a surgery, and I did not remove the crura. At that time, I was mentioning this to you earlier. I fractured the crura, I left it there, or maybe I did not fracture it enough. So she came back to me 7 years after the primary surgery and then said that she can't hear anymore. So obviously I had to go inside again. I opened up, and then I found that the piston was good. I first thought it was piston necrosis, incus necrosis. So I took out the piston. Can you see that? I'm taking out the piston with a small right pick. The incus looks pretty much normal to me. Can you see that? Absolutely normal. Blood vessels on it. The incus is moving. There is no malleoinguinal fixation. I'm moving the malleus, that also moves. So I'm taking the piston out. Now, what do I see? I see some soft tissue there. I take all that, and I find that there is the piston is still attached to the anterior crus. Can you see that? I'm sorry. The incus is still attached to the anterior crus. So I think here, when I fractured it, the anterior crus did not fracture. So I had to, I took out the anterior crus and put the piston back into the same fenestra that I made. I did not have to make a newer fenestra. The same piston goes back into the same fenestra. So you can snap it back onto the incus. Can you see that? You can actually snap it back. So here what I've done is I have not actually opened the piston, because if you open it, because it's an old piston, the elasticity may not be there. So I've actually taken the same piston, put it there, and with a right angle pick, snapped it back onto the incus long process where it stays there. So it's the same piston in the same fenestra. The only thing missing now was the anterior crus. Now here you can see this video. So this is a patient who had
this is a young lady with autosclerosis.
Can you see
a reasonably good result when I did stupidotomy for her in 2001. In 4 years, the conductive hearing loss returned. When we decided to go back in 12 years later, this is what I found.
Here also, you don't find the incus damage. That's a soft tissue that I kept there for a seal earlier. Solidly fixed foot plate. What I have done is I'm taking the skeeter and making the whole foot plate thin. Like I mentioned earlier, I'm using the gel foam to suck the blood. Measured the foot plate, measured the thickness, and then made the hole bigger. technique. First goes into the fenestra and then onto the incus. So this is what it is. After revision stapedotomy, you can see the hearing improvement. Goes to 30 dB from 50 dB. Now here is another patient who had Stapes surgery. There was a lot of difficulty in visualization, and the patient was sent to me. And some of the good things that you should do. Is my audio muted? No.
Yeah, perfect, perfect.
Okay.
A little bit, if you can raise your voice, it'll be great.
Okay. So the short incus, you can actually even try to put in a piston sometimes, but actually you ideally need a bucket handle. Can you see that? This is another case that you did a revision 2 days after the primary surgery. The original surgery was not done by me. A good surgeon who decided not to do it because he thought the incus was too short. But it's important that you have this bucket handle processes if it is needed. Now, here, this is something good. This is you have to see. Now, here was a patient who underwent surgery 10 years earlier to correct hearing loss, but okay, and then worsened. So I thought it must be some tympanoplasty that was done. So I went inside, and when I opened that ear, I found that there was incus. It was between the malleus and the stapes. Can you see that here?
Yeah.
Now, okay. Now here, when I took out this incus, the incus was nice. When I took out that, the malleus was good, and it was fine. The malleus was all right, and the stapes was completely fixed. So what I had to do was, I found the stapes was not moving at all. Can you see that? Completely fixed. Absolutely no movement. The round window was visible. So I cut out the stapes and removed it. And I'm drilling out the posterior crus with the skeeter. The superstructure was removed. That's the ideal method of taking out the crus without damaging or rocking the foot plate. Took a small piece of vein for harvesting. If you're using a malleovestibular process, you should always use a vein. Always. And then made a small fenestra. Put the vein graft. This chorda, however, is badly damaged. Put in a malleovestibular processes. And see, you have to clip it onto the malleus and gently manipulate it onto the foot plate. So it seems to be in good position. I put some fat over it just to be doubly sure. And then close the flap. Okay, now everybody thinks it's great. The patient heard well. And I went off to a small holiday to Goa. 2 days later, I get a phone call saying that the patient is really dizzy, throwing up like anything, and then has got himself readmitted back to the hospital with bleeding from the ear, vertigo, and vomiting. When I went and opened up, I found that there was a lot of blood clots inside the ear. Can you see that?
Yeah.
And then there were even blood clots inside the eardrum. Can you see it's all blue in color? Hemotympanum. I opened the flap, and there was still a lot of blood clots. Can you see that? Complete blood. The whole ear was filled with blood. And I took very gently over. This video looks nice, but it took me a very long time to remove it. And then I found the process was still there in position, but I wanted to be sure. So what I did was, after sucking out all that blood, I removed the processes and wanted to see how it was like. I removed the fat that was kept there just a few days back, took out the processes, and repositioned it back. I just wanted to be sure the process is really, with all the blood, it should not have gone outside. So that is how you manipulate it back into the vestibule. There. And I also tested the movement. You can see the round window reflex there.
Yeah.
And closed it with a little piece of tragal cartilage as a support. And everything was well. Now here, we did a post-op. That's a first revision stepidotomy that was done for something done many years back. And this was after the second surgery. Sorry, that got a bit mixed up. The tracheal pericardium that was taken
What
out.
was the reason for the bleeding?
I'll tell you that. So this is a re-revision. Next time that I did, I left again after 2 days. This is a second post-operative vertigo, and the hearing was really good after the second surgery. This is 3 months after the second surgery. Now, I wanted to find out what happened, why the patient had bleeding. So we did the auditing of this case. We found out that who took what, who did what. We actually found out that there was a new nurse who actually mixed the xylocaine and adrenaline that day. She actually, when we infiltrate, we use xylocaine with adrenaline, right? We mix it 1 in 100,000. There was this girl who actually put a whole vial of adrenaline inside that.
Oh.
So it is possibly rebound bleeding from too much of adrenaline. And when I went back into the anesthesia records, we also found that the patient had severe tachycardia during surgery. It must have been adrenaline. I think the whole thing points out to one fact that after that incident, I never let anyone mix my own adrenaline unless it's somebody that I know, my doctors. Because this was a clear reason why if you put too much of any drug, it can cause trouble. So this patient would have had a completely normal post-operative period, saved me my holiday as well as a lot of heartache if that adrenaline was right. So this is definitely because of excess adrenaline. Now, there is another case where, see, there is a patient who had an osteoplasty with that, and then when they did surgery, they found out that there was something wrong, and they did a procedure whereby they tried to interpose something between a necrosed incus. See, can you see that? And it actually was a fixed foot plate, which they didn't realize at the time. And here is one of the applications for a Kurz processor. See here, with a necrosed incus, you can still put a clip onto the remaining part of the necrosed incus. The clip actually stays there. And this patient, the surgery is now done 2 years back, and the hearing is still stable. I put a small piece of fascia over it and close it. Just an example of what to do. Now, somebody asked me about foot plate fractures. Now, this was a patient who actually had a surgery at another place, a good surgeon, who actually called me immediately after surgery. He said that, sir, I have done this surgery to staphylectomy, the foot plate fractured, there's some CSF, the perilymph leak, what shall I do? I told him, you can actually close it off now with a graft, with a fascia graft. Don't do anything. You can go back in later after maybe 6-7 months. And then if there is still a trouble, you can actually do I mean, if there's no leak, you can do a stepidotomy. So that's what he did. He actually sealed it off and then was afraid to open it again. So he sent it back to me. I should show you what happened. So here was an abandoned procedure. So left ear, again, I am raising the temporomatral flap. And I see immediately there's something abnormal. See, this is a very short incus, and there's a lot of perichondrium that is put on the foot plate. Can I see that? Yeah. So I'm actually trying to take out the perichondrium, which has become adhered there. So later I realized that it was a mistake to ask him to put perichondrium. It should have been some fat. It would have been easier to take off. So I took some time to take out. You can see how abnormal the incus is. I took out the perichondrium. It was actually very difficult to take it out. And then found that there was a fracture and leak. Can you see the perilymph leaking?
Yeah.
So here is what I did. I actually took out some vein graft, prepared a vein, and wanted to do a laser of make a hole. But whatever happened, I still could not make a proper hole. So what I did was I took out the whole foot plate. Got the whole foot plate. Can you see the whole foot plate? Kept the graft over it, and over the graft applied a standard processes. This was tense. I actually was worried because I didn't have a small hole to go into. I wanted to put it exactly where I wanted. I had to do it very, very slowly. And then the incus was slightly hypermobile. So that's what it did. So here, wait, let me just flip it. So here, and there is one more case that I want to discuss with you. So here, there is this patient who was 31 years of age, had many surgeries. At 2011, 2011, there was incudostapedial joint found fixed, incus was dislocated, and cartilage kept on stapes. There was no information on stapes mobility. Left ear was revised in 11 2003. Fenestra was made in a plate and 0.6 into 6 millimeter piston inserted and crimped onto the necrosed incus. Right ear, timonoplasty was done 10 2015. There was no information on ossicular status. All three were done at different places elsewhere. Can you believe what all this patient underwent? Now this patient comes to me, and then what my plan was to stop using the hearing aid in 1 year and there was a lot of external otitis, left endoral exploratory timinotomy with revision stepidotomy, choremalleovestibular processes under GA. This was my plan. So we did the surgery and look at the hearing improvement in the left ear. So you will think that, man, what a great result. Dr. Manoj operated and hearing improved from 90 dB to 45 dB. Brilliant. But the things did not happen that way. I tell you what happened. On the 16th of June 2017, I put a malleovestibular processes on the left ear. I used a skeeter and carbon dioxide laser and put an MVP. The hearing deteriorated to 68 dB, left ear. Now, that was it. I told him that we'll wait for 6 months and see. So he came back to me in December. In December 2017, I again operated. I put a left transcanal re-revision stepidotomy. I took that out. There was more bone obliteration. I drilled using skeeter and put in a malleovestibular process. The hearing went back to 72. It is a month after I did the surgery. So here we have a patient who had a failed surgery, multiple surgery, already 3 surgeries done. I do one, hearing reduces. I do the second, hearing reduces even further. I am completely in a fix. I do not know what to do. I tell this patient that, see, listen, this is only so much I can do. Let us tie a bone bridge or a cochlear implant. He tells me one important thing. He says, doc, both times you operated, I heard a little bit for the first few days and then it deteriorated. Maybe that you did something, you did not do something enough. So I'm willing to risk it by making you operate on me 1 second. Look at that trust that patients give you. He's already had 3 surgeries. He's already had 2 surgeries from me, 5, and wants me to operate on a 6th time. So which is what I did. So I did the re-revision. This time I made a bigger fenestra and put in a process. That is where we got the result. I shall show you the video. So here, that is a process that came out. And that is a fenestra. I do not know how it regrew so much. So I made a lot of holes and drilled again and again and reapplied the same fenestra into the vestibule after drilling.
So there's a question, Dr. Manoj. Can we have a question?
Yes.
So what is your procedure for persistent stapedial artery? This is a question from the audience.
Yeah. And now, thankfully, I've never had a persistent stapedial artery. Thankfully. I think if it comes, I will abandon it. Because I'm not worried about the small blood vessels that pass the stapes. A persistent stapedial artery is actually a branch of the internal carotid. Bleeding could be very severe. It could be bad. So I don't think it is worthwhile trying to do something silly there. So I think if I see a persistent stapedial artery, I will always abandon surgery. But if I see a small blood vessel, I do have a KTP laser, with which I will laser it off. Now, I told you a lot of bad stories, but there are also a lot of good stories. Look at this. Meenakshi, 59 years old. In 2005, I operated on her. After the hearing failed in the left ear, which was done 20 years back. So she was 30 years old when this was operated. The left ear was operated. The left ear actually deteriorated to 65 dB SN hearing loss. And the right ear at 67 dB mixed hearing loss. So in 2005, I operated on a right ear, did a 4.7 millimeter, 0.6 millimeter piston, standard technique, and the hearing improved at that time from 67 to 27. Can you see that? Now, 27 happened in 2005, 2005. This is 6 2005. 4 months later, the hearing was 27 dB. Left ear, of course, was a SN hearing loss. Now, this was 2005. 2007, The right ear still remained at 28. Can you see that? Left ear had gone down to 70. In 2009, the right ear was 32. 2 dB, you can give it for age, I think, because it was like 5 years after. The left ear had gone down to 72. So you can have a 2 dB dip on both sides. And then in 2016, the right ear was 35. 32. And in 2018, which is 13 years after primary surgery, when this lady is now 70 years old, 72 years old, is still 35 dB in the right ear, and the left ear has gone down to 80. 62 when I started off, 80 now. The right ear is 35. Now you have to look at this patient, this old lady who has now gone 15 years past her first surgery. Now what has happened? Her left ear has deteriorated over time. The right ear has deteriorated, but only so little. See? So this comes back to a point as to why we should operate on somebody with only hearing ear, or somebody with on the other side in autosclerosis. See, when you do surgery for autosclerosis on one side, the patient immediately hears well. Now, one of the arguments against operating on the second ear was that the Stapes patients always have progression. This is definitely not true. We know that a non-operated ear progresses more than an operated ear. We have seen that. There is SN loss happening. We really do not know why people with autosclerosis, after having stepidotomy, tends to retain their hearing for a very long period of time. I might have told you all those stories, but all of them patients have had good hearing for many years now. So it is important that when you have somebody like this who has lost hearing in that ear following surgery, to be scared and not to operate on a right ear would have been truly criminal. Because she at 70, with a 35 dB hearing loss in 1 year, still does not need to use a hearing aid. So I think this message has to be loud and clear. Autosclerosis surgery should not be done if there is a grievous problem, an impending gusher, a stapedial artery, an abnormal facial nerve running on the stapes foot plate, a completely obliterated round window. No. But in other cases, the so-called your contraindications, only hearing ear, mixed hearing loss, should not actually be an impediment to somebody giving a good hearing, because today, even if this fails, you still have an option for a cochlear implant. I agree that counseling is of great importance. You need to counsel patients, you need to tell them what happens if it fails. But still, if you operate on someone and give them hearing like this for 18 years, it's still worth it, worth all the trouble. Now, this is the patient.
Can we have a question, please?
Yes.
Now, there are many people who are watching you who are also doing endoscopic approach stapedectomy.
Yes.
So, what is your frank opinion on endoscopic stapedectomy?
You're getting me to a fix. Okay. Now,
so many people who are watching.
I agree. Now, I always felt that Stapes surgery is the most delicate of all surgeries. The most delicate. I'm not talking about most delicate ear surgery. I think the most delicate surgeries of all time. See, because you're looking at a 2 millimeter gap, a foot plate, you're making a 0.8 millimeter fenestra, you're putting in a 0.6 millimeter piston that is 4.5 millimeter long. And what could get more exact than that? Now, when you're doing endoscopic stapedectomy, I've seen this being done. It is okay, it is done. But when you're doing this, there are two important limiting factors. One, you don't have two hands. Now, you can agree that you can say that you can put an endoscope, fix it onto a holder. But in the canal, if the endoscope is inside, which is what you want to need to get a panoramic view, you're actually removing off 3 millimeters from an 8 millimeter canal, which is like you're cutting off 40% of your canal size. There is no way you can manipulate around that. For a large proportion of autosclerosis patients, you have a canal, you have a foot plate which can take a lot of damage, which means that you can make a fenestra and put in a piston like 1.5 millimeter inside. Probably nothing will happen. But there is a small group of patients who will have dizziness and vertigo. There'll be a small group of patients who will have a foot plate saccule very near the foot plate. So you cannot go more than that 0.4 millimeter into the vestibule. You have to be exact. It is like saying that I've been driving 30 years without a seatbelt, nothing has happened to me. That's not right. It can happen to you one day. So you're looking at, in surgery, you always look at that one little thing that can go wrong and which can make that particular patient's life miserable or hell. And that is not right. So if you are looking at, if you are going to be doing Stapes surgery and going to be doing it well, you need to have two things. One, you need to have two hands. and you need to have the whole ear canal to manipulate your instruments. And you need to have excellent depth of vision. Why has God given us both eyes? For three-dimensional vision. And however good an endoscope may be, if you look at that 0.4 millimeter, 0.5 millimeter thing, no endoscope can give you that much of access. Janaki here is a fantastic endoscopic surgeon, but I think he would completely agree with me in saying that the precision level required for Stapes process going into the vestibule is beyond the capability of an endoscope.
Yeah.
I think it is there.
So, you are now being very diplomatic, bringing me into the whole picture. Actually, your clear message is that, endoscopic staphylectomy is not a very great thing to do.
It makes me afraid. It
No.
makes me afraid.
No.
Yeah, that's what it is. So no, I'm not bringing into it, Janaki. I'm just saying that you can only compare a person with great skill to application in a surgery that requires big skill. Okay. Now, I can't compare somebody who's been doing endoscopic ear surgery for 3 years and compare to me doing staphylectomy for 28 years. It is not fair.
Yeah.
It's not fair at all. I'm not bringing into it for diplomacy. I'm only comparing you because I'm only comparing someone who can work around the carotid, who can take stuff like that. I'm only comparing people like that. I can't compare somebody who's a novice endoscopic surgeon and then compare him to me. It is not fair at all.
Maybe we need more studies, a single surgeon doing endoscopic versus microscopic, and then maybe we may get an answer to this.
Yeah. That's probably the right way to do. But I still feel that, I agree that endoscopic ear surgery has got its roles. I also do use endoscope when I do cholesteatoma surgery. You can see into cavities that you have not seen before. You can see areas behind bone. But I still believe that endoscopic ear surgery is there to stay. It has got its role. But staphylectomy, I would be very, very, very cautious. Similarly, cochlear implants, I don't think it works.
Okay.
Now,
Yes.
cochlear autosclerosis is something that you can pick up by these two lines. Can you see that? So if you have somebody with a basal turn and you see a second basal turn, this is called the pericochlear lucency sign of cochlear autosclerosis. We went through this again. So when you have something like this, you can actually do a cochlear implantation where this is the bone that you are drilling posterior tympanotomy, and you can see how, let me freeze it there. So this is the round window area that we have drilled. Can you see that? Now this is something that you never see in a normal cochlear implant, never. This area is like this. It is the area where you have a blue area like you do a fenestra in a footplate. You can see the same fenestra thing in a round window. And when you see this, you know that for sure it is cochlear autosclerosis. And when you have something like this, you need to use an electrode that has got not a completely banded. It has to be stimulating only on one side because it can easily stimulate the facial nerve and cause facial twitching. So I am actually drilling through it, and you can see the muck inside that is widely opened. This is one condition where I will never ever try to do a round window insertion. I will always do a cochleostomy, and special electrodes are recommended in facial nerve stimulation is common. So, when we talk,
can we ask a few questions more?
Yes.
Number one is that you were talking about a curette being used for the bony overhang.
yes,
Do you recommend the use of either micro drills or I've seen Ashim Desai, Professor Ashim Desai using special equipment just to
chisel, a chisel, right?
Yeah. Do you recommend such instruments also?
No, I agree. See, Robert Von Zahn uses a chisel. Have you seen him? I use a chisel. It's brilliant. He keeps a small chisel. He's got a small hammer, and if one hit, and the whole overhang comes out. I probably am not very good at that. I still think if you can use a chisel with great precision, it's actually very good. Micro drill, I wouldn't recommend. You know why I don't recommend? Because micro drill will definitely damage the chorda tympani. The chorda tympani will be damaged if you use a micro drill because it gets caught onto it. There's no way you can separate the micro drill and the chorda. Micro drill can be used. I've seen people using it. You can use a skeeter with a cutting blade. You can drill out the crura in the posterior superior overhang and use it. But wherever I have seen it being done, I've seen it catching the coda. I have not seen it cutting the coda, but I've seen it catching the coda. And catching the coda means coda gets damaged. You cannot save it. But if you have a chisel and you can use it well, like Wansan does, I think it is brilliant. I've seen him using it. It is fantastic. But because I've been used to the curate for a very long period of time, I don't want to be using the chisel anymore.
Second question is that if you have a patient with a foot plate which has gone into, that is a submerged foot plate,
Okay.
so what would you do?
Now, ideally, like I said earlier, you don't want it to happen. Okay. Now, which is why all this talk was focused on how not to let it happen. But I agree. But if it sinks into the vestibule, now you must understand that it's a terrible thing to happen. But on the good side, probably nothing might go wrong. Probably. Because a sunk foot plate might just settle there. It might go touch the saccule. It might cause a little bit of giddiness over time. But over a period of time, fibrosis happens, it settles down. But the worst thing can happen when it goes inside and penetrates the saccule, and then it causes profound hearing loss. So if you are operating using using whatever instrument, and a small piece of foot plate goes inside, I still think don't panic. Because I think at that point of time, it would be well advised to actually put a small piece of vein or a thin piece of fascia over the foot plate and leave it there, because the foot plate actually floats upwards because there is some pressure of the perilymphatic system inside, and it might get fused to the fascia that you keep there. People have also said that you keep a drop of blood, it'll fix to the floater foot plate which you can take out. But I think if you see a floater, the best thing would be to leave it there. It kind of fuses over time. And you can either leave it there and give the patient a hearing aid, or go back in again and then see whether you can laser it and take it and kind of see. The carbon dioxide laser actually is very good. You can actually go deeper into the water without actually causing heat inside. The heat generated by CO2 laser is very low. They can probably lyse out a foot plate that has gone inside with some risk, of course, but it can be done. But I think if I had an issue like that, I would actually seal it off and try not to do anything in that year again.
Would you then, I mean, I've seen surgeons doing the POTS technique, that is trying to lift that foot plate up. Would you recommend that?
No, which is what I did. You saw me doing it. The case that I showed, the revision case that I showed, I actually lifted the whole foot plate out, which is actually good. So you can actually, if the part of it is right, you can actually take a hook and lift the whole foot plate out and make it a total stepidotomy.
Okay. Yeah, please carry on.
Okay. So the results that we are showing today, the technology has certainly helped us to shorten the learning curve. I think today, if a surgeon wants to do stepidotomy really well, I think he can actually learn it faster than what I did. Because we went through this big process of operating with bad microscope, bad instruments, and then having the skeeter, and then having good microscope, then the laser. I think people today might have more access if they work long enough with someone, can use the newer tools and thereby shorten the learning curve, which is a very good thing. Technology has to be used. It has to be used. If people don't use technology, actually do stay behind. There are, of course, people who are brilliant people. I have seen fantastic surgeons who don't use a laser, don't use a skeeter, and give fabulous results. But those are artists. Those are people who are beyond us. They are people with far greater ability than what we will ever have. But not everyone is like that. Vast majority of us are people with good skill, but not extraordinary skill. But for people like us, we do need technology to make us better. Now, there is also the saying which many people use, is called a fool with a tool is still a fool, and more powerful the tool, more dangerous the fool. So if you have good instruments, unless you are trained well, you should not be using them. So laser, microdisc, and special processor reduce much of the mistakes in Stapes surgery. If today, my patients leave surgery 2 hours later. I do surgery in the morning, they do 2 hours. Our post-operative vertigo, I don't remember any patient in the last many years who have had any post-operative vertigo. There have been a rare patient having post-operative SM hearing loss, delayed. We don't know why. We know that this happens sometimes, but it's been very low. I think it's less than 0.5%. It's still there, which means that you still counsel for profound SNHL. This is clearly said. In our consent form is clearly mentioned that staphyrectomy surgery can cause profound hearing loss in 1%. This 1% is more than my actual incidence, but I don't think I can be happy about that. My whole of my results can be screwed up next year when I will have some few cases which will make my whole statistics come back to 1%. So we don't worry about what happens the next 4 years. We worry about what happens the next 5 years. So to conclude this whole talk, everything about staphyrectomy is about precision. You have to be prepared for the complete unexpected. Sometimes you go inside, you don't find the meniscus properly, you find an abnormal facial nerve, you find an ossified foot plate, you find a big artery, you find a floater, you find a possible blusher. Revision surgery is for the more experienced. We should know which surgeries to do, which surgeries you should not do. I don't think that anybody should be saying that don't do any step, you send it to everyone. If you are good enough, if you can handle the ossicoplasties well, you should be able to do staphyrectomy. See, the learning curve towards ear surgery is like this. You start off by doing your tympanoplastics. Okay. And then you get better with your tympanoplastics. You find that your graft take-up improves, your patient is getting better, there's nothing happening. You gradually move on to ossiculoplasty. Now, when you do ossicoplasty, you do many things. You look at the mobility of the ossicular chain. You actually find out how mobile the incus is, how mobile the stapes is, and what the stapes foot plate mobility is. Once you start doing ossicoplasties on the mobile foot plate, you know how much of force you can put on the foot plate, on the stapes. Now, you have to audit your own results. You find that you're doing ossicoplasties, 50 of them, 100 of them, and none of your patients seem to be having vertigo. None of them seem to be having SN hearing loss. Then you can promote yourself to somebody who can possibly try a stapes surgery. And when you start off with stapes surgery, take out the large canals, the non-difficult ones with not so much a mixed hearing loss, relatively early cases with 35, 40 dB hearing loss. And once you've gone through about 40, 50 of them, you can take the ones that have mixed hearing loss and then gradually proceed on to the ones that are more severe. Now, when you have done many hundreds of staphyrectomies, that is when you go for the revision staphyrectomy, which is because revisions are very, very difficult. Even for people like me, I've been operating for 20 years. I think my stapes surgery, I've gone to many thousands. I don't actually count my surgeries. But I think for me, a revision is a time when I'm actually quite tense. And you saw from my examples that revisions are never easy. There are cases that I've mentioned that where you have a person who can actually have re-revision of the revision that I did, person who actually you have to operate many times to get better, people who have abnormal incussus, people who have bleeding, people who have abnormal foot plate, refixation. So all these things are very, very difficult, never meant for the novice surgeon. And at any point of time, you should never forget the potential for hearing loss. Every surgery can possibly end up in profound hearing loss. So when you are counseling a patient with see, this is where counseling comes in. Imagine that you are a surgeon, you have done 10 staphyrectomies. Let's look at this possibility. So now somebody comes in front of you and sits down and says, "Doc, I want to do staphyrectomy. Will you do it?" You obviously say, "Yes, I will do it." And said, "What are the chances of my hearing loss?" I've gone to the internet and I've read that there is a possible hearing loss. And what would you say? You can say two things. You can say that statistically, staphyrectomy has got a 1% risk of hearing loss, which actually is not the untruth, but it's actually untrue because you have not done so many. But if you tell them that I have only done 10, he most probably will walk out and you'll never see him again. So how do you manage this? You say that, see, listen, I have done a few and I've done, I have done some good surgeries, but you must never forget that there is always a potential for hearing loss. And if there is a hearing loss, I will know what to do. You don't have to tell him that I will be referring him to X, Y, Z, but you can also say, I know what to do. And today, in this day, even if you develop a profound hearing loss, there is always technology to revert your hearing back to normal. See, I always thought that patients actually are not so much worried about complications. They're worried about what you actually are going to do with the complications. If you say that I can cause a hearing loss and after that I don't know what to do, that is what is most worrying for them. If somebody asks me, like, if I do a thyroid surgery, what will happen to my vocal cord? I say that, I mean, technically speaking, I can save your recurrent angina nerve all the time. But if at all it does, I know what to do to improve your voice if your cranial gets damaged. And that is what they want to hear. So whenever you're counseling patients for Stapes surgery, tell them that honestly, never lie. Tell them that there is a possibility for hearing loss, but if there is hearing loss, there are always technologies available to improve the hearing loss. So which is something that you need to do. So I hope, Janaki, that I have done enough in your trust. Thank you so much.
Dr. Manoj, I think it was extremely good, a fantastic lecture. Basically, you have conveyed everything through the lecture. I don't want to praise you much. You don't like praises, I know that. So, being very academic, let me congratulate you on your excellent work on Stapes surgery. And I hope the audience, we've actually, to tell you some statistics, we have actually got a huge number of audience who have seen you from all over the world. Can you stop the screen share, please? Can you stop the screen share?
Yeah.
We've had a huge number of people who have watched you from all over the world, like just to name some countries, South Africa, and then we've had a lot of Middle East countries, Mexico, Canada, America, and then this side, Indonesia. And I have the names of all those. I'll give you the exact statistics of how many people saw you. Maybe more than 3,000 or 4,000 people. So actually, these programs are done purely on the basis of academics, and I hope that the people who have seen it would have massively benefited from your vast experience on Stapes surgery. So thank you very much, Dr. Manoj. And just to remind the audience that we have one more. Just want to tell that this is actually a dedication to the Professor Stamberger, who passed away. We really are in deep sorrow to know that he was the greatest gentleman ever, and who propagated the concept of endoscopic sinus surgery. And really heartfelt, condolences to his family. And also want to tell you that 5th January, we have a program just dedicated to Professor Stamberger. I will try to bring in a lot of people. I'm going to talk with Professor Sethi tomorrow, who have all moved in close contact with Professor Stamberger. And I want to do a program just to dedicate it to him. And also we have one program on implantable hearing devices by Professor Mohan Kameshwaran. He's given a provisional date on January 19th. So thank you, Alembic. I know you're very, very, very academic, and thank you, Dr. Manoj, and thank you all for being with us. Have a good night, and God bless you all.
Thank you so much, Janaki. I would never have done it without you, and thanks again, Alembic. Thank you so much. I hope it went off without any major hazards.
Absolutely fantastic. Fantastic. So I just want to congratulate you on 2 things. Of course, I have to tell you, because one thing is your follow, the kind of records which you have maintained. This is actually one thing which all the juniors should actually see, how meticulous he has been on his audiogram charts over the years. So that is one point, very important carry home point. And number 2 is his clarity of thought and his quality of surgeries. So I think these are the 2 most important carry home messages. Very crystal clear images, no ambiguity, and very, very nicely done, Dr. Manoj. Big congratulations to you. Thank you.
Thank you so much, Janaki. Thank you so much. Really appreciate it. Thank you. Bye-bye.
Bye-bye. Good night. Stop meeting.